So now it's my pleasure to introduce the next moderator, and it's Professor Elisabeth Olhager from Lund. And she's also, now you have to listen carefully, because this is extremely important and impressive. She's head of the departments of pediatric surgery and pediatric heart surgery, which is one of the most skilled centers in Europe, I think, actually. She's also head of pediatric cardiology, and she's head of pediatric intensive care and neonatal care.
Yeah.
So, but not, and also why I'm so happy for all of that, because that must be a lot of work, is that she's also NIDCAP certified. Can you imagine? In her position, we have a NIDCAP. Yeah, applause, standing applause. So, yeah, thank you very, very much for coming. And thank you for your work and all the initiatives you're taking. You're such an important person.
Oh, thank you. Thank you, Björn. Thank you for the very kind words. And hello to everyone. And thank you to Agnes and Stina for this very nice day. It's been so inspiring. And I have to go back to Lund tonight, so I will be leaving here around 6:45 or something. And so I'll sneak out if we are not finished. And actually, I'm leaving because we are having a pediatric cardiology meeting that we have once a year in Lund for nationally. And I was sitting here listening to all the presentations and thinking about the newborns with the cardiac malformations, because most of them are diagnosed prenatally, and then the children are born either in Lund or in Gothenburg. And as Björn said, the results in Sweden are extremely good when you talk about 30 days mortality rate. But when the infant is born with a very severe malformation, either cesarean section or normally delivery, one of the first things that happens to that baby is that the infant will have a transducer on the chest. And so and then they would go to the NICU and stabilized, and then to the PICU, and in a few days in the operating theater. So the parents are left behind. So we have a lot of work to do. So, Agnes, it's an honor for me to introduce you. You are a consultant in neonatology, and now also head of the department in Huddinge, neonatal department in Huddinge. And we have heard that you have been very involved in the IPISTOSS studies, and you presented your PhD in June last year. So, very welcome.
Thank you, Elisabeth. So now on to the results, or some of the results of the immediate parent-infant skin-to-skin study. I think you already heard something about this from Siri earlier on. But now I'm going to present the results from the primary outcome. So something about infant physiology during skin-to-skin contact. First, some background. So especially to this audience, I don't think I need to say anything really about the benefits of kangaroo mother care or skin-to-skin contact. And they are well established and well described in the literature. However, it was only last fall that international recommendations included unstable preterm and low birth weight infants immediately after birth. Before that, WHO guidelines said to wait until the low birth weight infant is stable, because skin-to-skin contact may be dangerous, actually. So the knowledge gap would be, well, partly actually the settings that most of us work in, high-resource settings. The body of literature in skin-to-skin contact is actually studies in low-income countries, and it's not hard to understand that skin-to-skin contact is much better than a very poor level of neonatal care. But what about the effects in Stockholm at Karolinska and in Uppsala? I'm not saying that there is no research. Uppsala, you do a lot, and now we've done some studies in Sweden too, but we know very little about the effects of skin-to-skin contact integrated in neonatal care, and especially intensive care. And also we know very little about skin-to-skin contact immediately after birth, so the first hours. Early skin-to-skin contact in papers is usually during the first days, so early may be subjective, I think. So the research question for the IPISTOSS team was whether skin-to-skin contact initiated immediately after birth and continued throughout the period that's important for the transition from fetal life to newborn life. Then what are the effects of skin-to-skin contact during this period compared to conventional care? And conventional care, sad to say, for preterm infants in Sweden, it's separation from the mother, except for in Gävle. So the immediate parent-infant skin-to-skin study recruited very preterm infants, so from 28 plus 0 weeks to 32.6 weeks, and the intervention was, as I said, skin-to-skin contact immediately after birth and continued during the first 6 postnatal hours. This is a period that's very dynamic, you know, how much happens in the circulation, how the child transitions from the fetal circulation. The control group was conventional care. And conventional care at Karolinska is care in an incubator. It's considered a quality marker to be undisturbed in your incubator as early as possible in our setting. And then, of course, skin-to-skin contact is part of neonatal care, but usually initiated later on. The outcomes, the primary outcome was the Scripps score. This concept may be unfamiliar to some of you, and I'll show you a slide to describe this soon. And then we had some secondary outcomes. I'll talk a bit today about thermal control, thermal regulation. And we also looked at many other outcomes, such as breastfeeding, parental experiences, you heard from Siri, and also something about stress reactivity and some long-term outcomes. However, we haven't analyzed and published those things yet. So this is a flow chart to, I don't know if you can read it at all, but it's to describe that we included 91 infants in our study, and that we informed about the study in the obstetric unit. So usually we asked for consent from families that were expecting a preterm baby. And the study subjects looked like this. So there were 46 infants in the skin-to-skin contact group. I've added also the mothers because we look at maternal outcomes as well. In the control group, there were 45 infants from 35 mothers. And you can see that on average, the IPISTOSS baby was a 31-weeker of 1.5 kilos. And the rest of the points there, you can just see that the randomization had worked quite well, except for females. There were more females by chance in the control group, and we had to adjust for that when we did the analyses. And I think many of these pictures look familiar to you by now. These are pictures that Stina has taken, and Siri has shown some of them earlier today. But this is just to show practically how we did it. So basically we saw the mother or father and the infant as a couplet, and we had to move ourselves with the equipment to where the couplet was receiving care. So lots of equipment in the delivery room, for example. So what about the dose of skin-to-skin contact or the exposure? Because of course some things were happening during the first 6 postnatal hours that could not be done during skin-to-skin contact. So, for example, umbilical catheterization and X-ray was not done in skin-to-skin contact, so we took a pause for those things. So the median initiation time was at 25 postnatal minutes for the group as a whole, but earlier for the older infants and a bit later for the more immature infants. And the median duration of skin-to-skin contact was not the entire 6 hours, but 5 hours. So again, more for the mature infants and a bit less for the immature group. And you can see here that actually we did a kangaroo father care study because we had a lot of paternal skin-to-skin contact for practical reasons. I'm sure you will ask me about that later on. So this is the SCRIP score. Thank you, Dr. Bergman, for this. I don't know if you've seen that before, but basically we looked at physiological parameters, so circulatory and respiratory parameters in the child. And they were divided in 3 domains, so heart rate, oxygenation, and respiration. And we scored them. It's a bit similar to the APGAR score, even though it's not the same items, but a perfect heart rate, oxygenation, or respiration received a 2, and then the intermediate values received a 1, and if the child was really outside what we considered healthy ranges, then there was a 0. So for each observation, the child received 0 to 6, because 3 domains and 0 to 2 per domain. And this is the result in one figure. So what you're looking at now is the mean SCRIP scores over time. So we observed the infant for 15 assessments during the first 6 postnatal hours. And on the y-axis, you can see the mean SCRIP score ranging from 0 to 6. On the y-axis, you can see the time in minutes from 0 to 360 minutes post-birth. The green bars are the standard errors, and you can see the red line are the mean SCRIP scores for infants in skin-to-skin contact, and the blue line represents the control infants. So this graph shows that infants allocated to skin contact, they had higher SCRIP scores, and they increased in SCRIP scores a bit faster than those in the control group. And this was also described statistically, which you can see in the publication. And this is the reference that was published in ACTA last year, if you want to look at the statistics more. Then another one of the physiological parameters that we analyzed was temperature. And this was published by Dr. Lode Koltz and us recently. So here you see the same type of graph with temperature on the y-axis and time on the x-axis. And here also skin-to-skin contact is the red line, and conventional care is the blue line. So in this picture you can see that both groups had normal temperatures. So our conclusion was that in skin-to-skin contact thermoregulation works, so no infants get cold or so. But you can see how the red line, the infants in skin-to-skin contact, they seem to have a more stable temperature, whereas infants in the control group, they have higher and lower temperatures, and we were only speculating, but sometimes for infants in incubator care, if they're cold, we increase the incubator temperature, but sometimes overshoot, and they're less stable, whereas possibly the parent and infant, they co-regulate a bit to keep a more stable temperature, but that's, I mean, from our research, that's only speculative, but it can be shown in other previous studies. And this is the reference for the study, or the temperature analysis. So I'm already coming to the end of my talk. So the conclusion from the physiological analysis in the IPISTOSS study is that immediate skin-to-skin contact may help the very preterm infants through the transition from fetal to newborn life. And this is actually the other way around compared to earlier recommendations. So it has been recommended before that you need to wait, the child needs to become stable, but we are saying that maybe you need to start in order for the child to become stable. And also in the long run, I think you could safely say that an uneventful transition will actually be good in the long run for the child too, because the easier the transition goes, the less stressful the first hours are for the child, the more likely it is that the child will be left alone with the parents. You know, if the infant needs a lot of oxygen, then the doctor will come and ask for a blood gas or a chest x-ray, which will be stressful. Oh, I'm undressing here, sorry. And that in the long run will possibly expose the child to more stressful experiences. So with that, I would like to thank the IPISTOSS team. I think there are many familiar faces in this picture to you. Nils Bergman, he conceptualized the study together with Björn Westrup, who was also the sponsor. Vibke Jonas, she's the PI of the study, together with Siren Rettedal, who's our colleague in Stavanger in Norway. This study was done in Stockholm and in Stavanger. And there's myself and Stina and Siri. We're all here today. And then the colleagues from Norway, Caroline Lode-Kolz and Hanna Markus, and our research nurses, Kerstin and Camilla and Kirsten. So thank you all.
Do we take the questions now?
We can do that.
One, yeah. Yeah, please. Microphone.
Where? Copenhagen.
So my name is Ponti from Copenhagen. I'm a physician. Thank you for a beautiful talk and very nice study. Does this mean that we don't have to do any more studies? That this study can prove that we don't harm the children? I can go back home and say, okay, we can implement this, because you said it can help the infants, but I think it's also important to say that it doesn't harm them.
This is a very good question, because the way I see it, incubator care in neonatology, there are really no studies on that. We just assume that that's the best. So do you need to prove that it's dangerous, or do you need to, I mean, either you assume that there's a best thing or you try. And I think our results, they indicate that skin-to-skin contact is the best place during the first hours. However, I think it's very important to look at the risk with skin-to-skin contact too, because skin-to-skin contact has a very good reputation. And I think that if you want to implement in a higher scale, then you also need to know what the risks are. But I'm not aware of any studies describing advantages with incubator care over skin-to-skin contact. I don't know if you do. No?
You're the expert. I'm just asking.
Should we take a question from here? Yeah. There's a question coming in here. How do you do with cesarean sections?
Hence all the paternal skin-to-skin contact. Yeah. So that's why we had lots of fathers doing skin-to-skin contact. I firmly believe that mother is best during the first hours.
Why?
It was, well, because she will breastfeed, she gave birth, she's the familiar person to the child. So I think so. I mean, the father will have an important role very shortly after, but those very first hours, mom is best. But for practical reasons, it was tricky to get in the operating theater with CPAPs and things. So we sort of took the easy way out and picked one parent.
There is one more question up there.
First, thank you very much. I am Töre Hanaslan from Turkey. It is very good and nice study. Thank you very much for your efforts. How did you randomize the groups between the groups?
Yeah, so we had
How?
two strata to run. So we have I'll explain it instead of showing the slide. We divided in two strata, one for smaller infants, 28 to 30 plus 6, and one for the bigger ones, 31 to 32 plus 6. So we randomized those separately, and then we had an electronic randomization tool per site. So we had site strata and gestational age strata, and then I think there were uneven blocks in the randomization. Yeah. Thank you.
Thank you very much, Agnes.
Oh, maybe one more.
Sorry. Go ahead.
Björn is prompting me here. I think the next speaker is going to talk about the delayed cord clamping. And to answer your question from the Copenhagen, actually, the study was not immediate. It was as early as was possible. What is the definition of immediate? It's a convention. But in the Cochrane reviews that we wrote, started writing 20 years ago, we made 10 minutes as our boundary of immediate and 1 hour as our boundary of early. So by all means, when you go back to Copenhagen, maybe tomorrow you can write the protocol, and on Monday you can start immediate. And then the father story. I would concur with Agnes. Really, the father is really good, and the father can really do it. But there's a certain difference that we've lost. Agnes, I would agree concurrently that we would want to try and prioritize the mother a great deal more than our systems allow. The fact that we can do skin to skin, we should be proud. But we'd be more proud if we then had a more focus on the mothers. And what we've not heard from here also is that we've got a long way to go to improve our breastfeeding rates.
Thank you very much,
Thank you.
Agnes.